Hi, my name is Onice Tamayo, and right now I'm going to talk about therapeutic clearance of amyloid by antibodies to serum amyloid B component. Definition: it is the main component of secondary amyloid plaques deposited in major organs as a consequence of chronic inflammatory disease. The AAS family contains a number of different apolipoproteins expressed, which are synthesized mainly by the liver, can be divided into two classes according to its ability to respond to inflammatory stimuli and according to its biologic function.
Serum amyloid P component. Amyloid P component is a small, non-fibrillar glycoprotein found in normal serum and in all amyloid deposits. It has a pentagonal, pentaxon, structure. It is an acute phase protein, modulates immunologic responses, inhibits elastase, and has been suggested as an indicator of liver disease.
Applications in medicine. Current treatment consists of support or replacement of defective organs and measures to reduce the abundance of the amyloid fibril precursor protein. A sufficient reduction in the supply of precursors stops the accumulation of amyloid and can reduce morbidity and mortality. However, amyloid regression is very slow and often doesn't occur at all, in contrast to the generally rapid removal of other extracellular debris and efficient tissues remodeling, for example, after trauma.
Imaging is starting to play an important role now and is emerging, particularly imaging with MRI, that turned out to be a rather sensitive way to detect amyloid involvement and also to follow the amyloid deposit through therapy. This is particularly important now because, as Dr. Palladini will explain in his part of this afternoon session, new drugs are appearing now that can target the amyloid deposit. This is passive immunotherapy, and we have at least 3 antibodies that are under test in the clinic. One is NEOD-001, that was the first one to be exploited. The second one is being proposed by the London group that is targeting SAP. Is a combined actually treatment, previous treatment with a small molecule that clear SAP from the circulation, followed by the antibody that target the residual SAP in the amyloid deposit, rapidly accelerating the removal of the amyloid deposit. And the third antibody has been developed by Dr. Solomon and by our colleague at Columbia University, that also has been reported in several meetings to be rather promising. So the aim of this antibody is to accelerate the recovery of organ dysfunction, particularly the heart, with the hope to further improve the outlook of these patients.
Pros and cons. Pros: patients with a new diagnostic of systemic amyloidosis require a rapid and safe removal of amyloid deposits to maintain or restore the function of vital organs, so that measures to reduce the production of the amyloid fibril precursor protein and thus stopping the accumulations of amyloid can be effected. Cons: The amyloid load categories were as follows: small, deafening or uptake but substantial blood-pool signal; moderate, more intense organ localizations and reduced blood-pool signal; and heavy, very strong organ localization with little or no accumulation of blood.
Traditional treatment of amyloidosis has been chemotherapy directed at the plasma cells responsible for the production of amyloid. However, that does nothing for resident amyloid deposits that are already established. NEOD1 is a monoclonal antibody that has epitope-specific binding to amyloid fibrils and can assist in the dissolution of those fibrils. Today we're reporting on 69 patients with light chain amyloidosis having completed chemotherapy with persistent organ dysfunction. And what we demonstrate is very fast organ responses, median 2 to 4 months. And in addition to that, we saw responses in half the patients with renal amyloid, approximately half the patients with cardiac amyloid, and 80% of the patients with peripheral nerve amyloid. This adds to our ability to effectively manage amyloidosis by directing treatment at the misfolded fibril, allowing it to be dissolved. Moreover, we demonstrate that the response from NEO is actually unrelated to the prior chemotherapy, since it was not dependent on the depth of response or the duration between the cessation of chemotherapy and the initiation of NEO. Amyloidosis really has three potential targets. One is synthesis, directed at the plasma cell. Our primary therapy is stem cell transplantation, but that's only applicable to approximately 1/3 of our patients. For the remaining 2/3, the choices are either oral melphalan dexamethasone or cyclophosphamide bortezomib dexamethasone. So that's the strategy directed to the plasma cell. There are also strategies to reduce misfolding, and there's some evidence that doxycycline in cardiac amyloid may reduce the misfolding and improve outcomes. The third is to actually dissolve existing amyloid deposits, and at this point in time, only one monoclonal antibody is being actively investigated, that being NEOD, to dissolve resident amyloid deposits.
Issue supply in Ecuador: 3 episodes of hepchat and 1 brief episode of nausea during CPHPC exposure. Most patients who receive more than 200 mg of MD-SIP antibody experience self-limited transient symptoms during and up to 12 hours, and the infection, including but not limited to sensations of head, flushings, headshot, increase and decrease heart rate.
I have a history in the family from amyloidosis. My father had it, and 5 of my uncles and 1 of my aunts had it, and 2 great uncles that we think had it. So I was very, excuse me, I was very familiar to what to be looking for.
It took about 8 years to get the diagnosis of amyloidosis, and he saw about 14 doctors before he got his diagnosis.
About took her 5 years to get it diagnosed, right? Then once she got it diagnosed, she knew what it was, right? After that, they had me take the fat pad or get tested for the gene. And at the time, I didn't expect any, because I had no symptoms at all, right? And just think, okay, let's see if I have the gene or not. And lo and behold, not only did I have the gene, they found out it was active in me. And So from there, it's been, it's progressed up to, right now, up to my ankles. So it's something that I have all the time.
When I was diagnosed, I was in heart failure, liver failure, and kidney failure. And I was on dialysis.
So Kat got to a point where we just got a real soft rug, and I spent many nights, I just slept in the bathroom so I could get 5 or 6 minutes of sleep.
It was kind of, you've been to all these doctors, what are you doing here? And I said, we're kind of looking for a silver bullet. And he said there's no silver bullet.
We need something that will at least, if not a cure, will at least improve our quality of life. Whether it's neuropathy, orthostatic hypotension, whether it's bowel issues, whether it's kidneys, eyes, whatever. But whatever it is, it may be a combination of things, but at least improve the quality of life.
I think that the criteria shouldn't be as rigid as it is in some of these trials, because all patients are different. Every organ is, you don't know what's going on in your body, what organ's getting affected. That's one of the worst things about the disease.
I think I got a placebo because I got worse. I went from walking to walking with a cane to using this.
The transplant I did in 2002 worked very well. There were a lot of risk. My heart was involved heavily. Still, I took the risk of the transplant because otherwise they were giving me 6 months to live, and at 53, that was very hard to accept.
It's so strange conceptually, because it really is a terminal illness at this point that nothing feels risky.
Knowing my history, my family history, that was a no-brainer for me. I'll go on any trial I can possibly can. I know it's not going to help me. I feel I'm beyond that point, but it will help someone else.
I went from a point of really not wanting to be here, and my main thoughts at the time for going into a drug trial was to save my family, not me, to a point of where I feel good. I'm glad I'm alive. My quality of life is 6 times better, and it's exciting to tell, not to tell them, if you guys approve this, and if it's working, my family won't have to go through this. The second they find out they're starting to manifest, maybe a little diarrhea, they take this drug, they don't have to go through what I went through. You don't have to hit bottom and work your way back. So I'd like to tell them, man, prove this drug, it works, I'm proof.
I know that I am good enough right now, and I can live my life, but I need to get something that's going to prevent this thing from progressing, and time is what is so critical to me.
Having this disease is like standing on a cliff, and you know that the cliff is deteriorated and you're standing close to the edge.
In conclusion, patients with a new diagnostic of systemic amyloidosis require a rapid and safe removal of amyloid deposit to maintain or restore the functions of vital organs, so that the measures to reduce the production of the amyloid fibril precursor protein and stopping the accumulations of amyloid can be effected. Thank you.